I'm so honored to get this prize, and I want to dedicate it to people with schizophrenia and their families, and to the late Connie and Steve Lieber, who did so much for me and so much to build the BBRF and for other people working in this field. Here's a brief outline of my talk, quick personal history, something about the conditions of living with people with schizophrenia. Then I'll talk about a new study of schizophrenia and COVID-19. And then, on a more optimistic note, an opportunity that has arisen in this crisis that has to do with housing homeless people with schizophrenia. And finally, the broad implications. So my personal history, I've worked on so many angles of schizophrenia, it's not possible to present during this brief time. But I would say the overall theme is science for social and racial justice. I'll elaborate further later. And I've worked locally as well as globally. I've had so many mentors and collaborators, so many of them are close friends. It's not possible to talk about all of them here. So I just want to say that I see myself as part of a large thought collective. And even work I led, it's not just done by me, it's done by so many contributions from a collective of people. And I've already mentioned Connie and Steve, who are in the picture. I was in the first cohort to get a Young Investigator Award, and it was crucial to launching my career, like it has been for so many people, and so are the subsequent awards from NARSAD. As I get older, it seems more and more important what I got from my parents, so I do want to mention them quickly. They were Mervyn Susser and Zena Stain. In the top left, you'll see the picture of both of them in the obituary for my father in the South African newspaper. He's still known there for his work against apartheid and his work in setting up what I think was the first community-based health clinic for Africans in South Africa, and I think in all of Africa. On the right-hand side, you'll see a picture of the cover of the Dutch Family Study book. My mother led that study along with my father, and you might know that I continued to work on schizophrenia based on that study, and the work is still exciting things coming from it. And then finally, at the bottom right is a picture of my mother at 97. She's now 99, and with Mary Claire King next to her, and they're mutual admirers. And I'm in the picture, and Thomas Lerner is the other person in the picture. But I mention that partly because I learned so much from Mary Claire King, but also because my mother and her are so close. So, what are the living conditions of people with schizophrenia? Well, to me, when I say racial and social justice, for me, social justice means equity for people with schizophrenia. I think that's a crucial component of it. And the disadvantages that people with schizophrenia suffer from and the discrimination are maybe best summarized in this WHO document that was done with the United Nations Development Fund. And it details how people with schizophrenia across the globe are excluded from civil and political rights, often victims of violence and abuse, and very strikingly, have a much shorter lifespan than other people. So they are a disadvantaged population that the UN has said there ought to be given special consideration, that they're included in all the benefits of development and other kinds of changes. And in the United States, as you'll know, we have thousands of people with schizophrenia and other mental illnesses in prisons. We have thousands of people living on the streets, and that is unacceptable. And I can't see anyone who could think that that is a humane outcome. So we have much to do. And here is maybe the most extreme example of social exclusion, which was under the Nazis in Germany in World War II. They targeted people with schizophrenia for systematic killing. And they actually developed the methods that were later used at Auschwitz and other places. they developed those methods by experimenting on people with schizophrenia. And they sent them to institutions like the one pictured here. And yet it wasn't considered a war crime because that was for people that were discriminated against or killed because of race, religion, other things, but not disability. And I think disability should be included. This is extreme, but we have pretty examples not as bad as that, but quite bad, that began before that in the most developed countries and continued until the 1990s in some of them. And one example would be involuntary sterilization. The Nazis also used that earlier. The idea was to prevent contamination of the Aryan race with people with schizophrenia. But it's not so different, unfortunately, for some of the views expressed today. What about schizophrenia and its impacts on people that have it? Well, the metric we usually use nowadays in thinking about health is the global burden of disease data. And in those data, schizophrenia is associated with more disability over the life course than almost any other illness. And so we hope to change that. We have to change that. And it can be changed because a lot of the disability is due to the living conditions that people are in, and not just to the illness itself. There is a legal framework now, an international one, that we can draw on. It's probably best exemplified by the Convention on Persons with Disabilities. There are some controversial elements in this, but overall it's an excellent document. And one of the articles is equal recognition before the law. So this has been adopted by the vast majority of countries, provides a legal framework for putting an end to discrimination toward people with mental disabilities. And the big problem is implementation, which is not complete almost anywhere, and that's our task now. With that general context, I'm going to talk about now a new study of schizophrenia and COVID-19, because the pandemic is severely affecting the lives of people with schizophrenia. Those are the current conditions, as well as everyone else's lives. There have been previous studies, not definitive, but they suggest that infection and hospitalization are higher among people with schizophrenia than among other people, and that vaccination rates are lower in the absence of targeted programs. What I'm going to talk about is a new and I hope more definitive study from Chile on some of these points. These are preliminary results, and this was done in collaboration with the Chilean Mental Health Registry. And please don't cite them as final results. You may not know that Chile has a long tradition of national registries. It goes back to the 40s and 50s of the last century. And that is very unusual for what was, for almost all that time, a middle-income country. And on top of the registries that have existed for a long time, there are two recent innovations we're going to rely upon. One is the first episode psychosis registry that was established in 2005. Anyone identified as having a first episode psychosis, and the methods of identification are very good in Chile. Anyone with that designation is mandated to receive a thorough diagnostic process, to receive early intervention services at low or no cost, and will be followed in the registry. And the second innovation is that only recently, in 2020, the FEP registry, as I'll call it, was linked to many of the other registries that Chile has, wide array of registries, via national ID. And I'm going to show you that. So here's what you have in Chile. You have the FEP registry, which has a lot of information in it. I won't detail. It's connected to a birth registry, a death registry, all kinds of community-level data, family-level data, then morbidity data on physical as well as mental illnesses, And finally, on school data, which I think are among the best school data in any registry. I won't detail it further right now, but this is a gold mine for schizophrenia research, I think. Today, though, we're only going to use two registries. One is the FEP registry, which I've mentioned, and the other is the COVID-19 registry that is, of course, recent. And that has all COVID-19 infections, hospitalizations, mortality, and vaccinations. And an important point here is that unlike most countries and unlike the USA, vaccination was prioritized for people with severe mental illnesses. So we'll see what the results of that policy have been. Here's the general picture. In red is the rate of infection for people who had a first episode psychosis since 2005, and in black is the infection rate for the general population from March 2020 to August 2021. And you'll see there wasn't much difference in the first wave, but in the second wave, which is much larger, people in the FEP group had a much higher rate of infection. This is actually turns out to be a valid comparison, but there are very different age structures to people who had a first episode psychosis and the general population. So just to show you that it pertains, here's the age group 25 to 34, where many of the people are clustered who had a first episode of psychosis since 2005. And again, in red is the rate among FEP of infection, and in black is the general population. And within this age group, not much in the first wave, but a huge difference in the second wave with a higher rate of infection among the FEP group. So there is a higher rate of infection among people with schizophrenia in Chile. So this is the slide that I think is most important, or most striking perhaps. And this is a slide of people 65 or above with FEP compared with the general population. And it's a slide of the rate of vaccination. I use this because initially, in the rollout of the vaccines, only people age 65 and above were eligible in Chile. So this is the only group that you can really study well at this point. And what you see here is that the vaccination campaign in the general population, which is in light green, was really very effective. But then you look at the dark green, which is the percent of FEP, people with FEP who've been fully vaccinated, and it's remarkable. It goes up higher than the general population quickly. It's almost up to 90% now, and it's still increasing at a faster rate than the general population. So prioritization works in Chile, and I think it could work elsewhere. It's hard in a very short time to say anything about the global situation for people with schizophrenia under COVID. But there is a study called MASK, which I'm part of. I don't lead it. And this study is led from London, and the work is done by investigators in 7 countries across 4 continents. The countries are listed below. And again, it's preliminary findings, so please don't cite them as final results. But generally, what's coming out of this study is that there are increased mental health needs, but reduced mental health services, and sometimes drastically reduced. There's increased abuse and discrimination. People with mental illness are not being prioritized, with exceptions like Chile, and previous social inequalities are being magnified. And that's very important for people with schizophrenia who tend to be poor. It's not all, this is a pretty distressing picture, but there have also been some innovations, not just in digital technology, but in other ways that might actually improve care in the future. So I don't want to present it as hopeless, but these are hard times. So following on that, here's something good that may emerge from the pandemic in the United States. And this is a completely unexpected opportunity that happened because we're in a time of crisis. This is a picture of a high-end hotel in New York called the Lucerne, where homeless people were moved from congregate shelters. These were single adults who were living in very close-quartered congregate shelters, and that was a kind of situation that was rife for the spread of COVID-19. So of necessity, the city moved a very large number of them to hotels that were vacant because of the decline in tourism and travel, and the hotels probably would have gone bankrupt without this. So what happened in New York? Well, here you can see that the number of homeless people in New York has tripled since the mid-1980s when I started working on this. And I couldn't have imagined then that instead of getting better, that it would be 3 times worse by now, 35 years later. And these are only people in shelters, not counting people in the streets. The majority are families who are very important, but I'm going to focus here on single adults because of what happened during COVID. And it's single adults that were living in these crowded conditions in the shelters. So when the pandemic came, out of sheer necessity, the city moved 10,000 single adults, approximately, and that's about half of all single adults in shelters. They moved them to approximately 60 pretty good hotels within a period of 2 months. So they reduced the single adult homeless population by half in 2 months. And I think that's a pivotal occurrence because it shows the problem's not intractable. It just keeps getting bigger, but that's because we don't do anything about it. It can be resolved. And the new mayor, who's incoming in New York in January, has promised to convert the hotels to housing for homeless people. It may not be permanent housing, but it's a base from which you can get permanent housing and you can get jobs and meet other needs. And this is not just New York. This has happened across much of the United States. The same kind of moves of homeless people to hotels in the context of the necessities of the pandemic. And some of these cities are converting hotels to housing already. And I think the prime example would be California, where the governor is using funds that were given for COVID-19 relief to convert hotels and vacant office spaces to housing under Project Home Key. Research on this is in its infancy because it's just, the thing itself is just beginning. But we have done some research, and current research suggests 2 important things. One is that the hotels are safe. Some people were afraid that people having their own rooms would lead to a much higher rate of overdoses and so forth, but that seems not to be the case. And the other is something expected, but that needs to be documented, which is that hotels greatly improve the quality of life compared with being homeless. We've set up a research and advocacy group that we call Hotels NYC. These are some publications from it. But we're more a research group than, although we also do advocacy. But the advocacy is done alongside much more powerful organizations. One is the Coalition for the Homeless. But another important source of advocacy are homeless people themselves. And that YouTube picture is of Shams Barron, who was nicknamed the homeless man, and he actually was moved from a shelter to the Lucerne. After that, he got permanent housing. But he's been talking with the incoming mayor, and I'm sure was a big influence on the incoming mayor's decision to go forward with conversion of hotels to housing. So what are the broad implications of all of this? I think that the implication is that we have to prioritize people with schizophrenia and other disabilities as declared by the WHO and the UN so that they can get the benefits of development and of other civil and political rights I think this is essential, it's feasible, but it's not often done. And our job is to get it done. Picture here is by Vincent van Gogh when he was in an insane asylum. And that's just to illustrate that so often people with schizophrenia are disregarded as though they didn't have capacities. But they do have many kinds of capacities, and many of them are even geniuses, as has been well documented. So what do we do? I believe we should do something that I call engaged scientific research on schizophrenia. And what that would mean in the United States is that when we train researchers and when we train mental health professionals, we should include in the training the civil and political rights of people with schizophrenia or other psychosocial disabilities. Most mental health professionals couldn't tell you even the basic elements, for example, of the UN Convention of Rights of People with Disabilities. We also need to take into account the legacy of racism, which is now being done much more. And that is important because it has had a pervasive influence on health and especially mental health services historically in the United States. And finally, for people who don't have it already, which I think is most trainees, there needs to be an experience of immersion to feel the living conditions that people are under in terms of housing and food and other aspects of life for people with schizophrenia, and experience of advocacy, because you need some experience in order to do it. Here are two people who were pioneers of this a long time ago, Paulo Freire from Brazil and Franco Basaglia, who built the Trieste in Italy community mental health movement. I want to be clear that I'm not suggesting in any way that we should slow down neurobiological research or genomic research. I do that myself. What I'm suggesting is that there should be another dimension to all of our work which pays attention to social equity for people with schizophrenia, and that we need this training in order to accomplish that. And how about the broader implications of COVID-19 for public health in this new world? We're confronting a confluence of urgent global threats. Not only the pandemic, which is surely just the first of many pandemics because we've created fertile ground for them, but also climate change. We're already seeing the effects of that. Massive displacements of refugees and increasing inequalities within countries and across countries. And these challenges are urgent. It's not, we cannot put our heads in the sand. We have to confront them because they're coming upon us now. And I think in that context, we have to start posing broader questions about changing the social order and do it in conjunction with social movements to which we can also contribute. And we have to learn how to do it because we're not used to asking broad questions about how changing national, global, or otherwise local structures that impacts on health and mental health of the population. But I think that's where we have to go. And then I'll say again, in the public health response, we need to ensure that people with schizophrenia and other disabilities are prioritized. That's really our job. So to move forward, we have to think globally. We have to think structurally. We have to see the world as dynamic as it is. We don't have time to lose. And so we need to be engaged and we need to promote social justice and equity. And finally, I just want to thank Franco Masciano and the people in the MinSal team in Chile for sharing our preliminary results here, and the MAS team also. And I'd like to thank Tahaya Boswell for the great help she gave me in preparing this presentation. Thank you.